All right, now we've talked about reproductive health for both men and women, and now we're going to talk some about fertility. I'm going to start with infertility. This people who are having difficulty conceiving when they want to conceive. The incidence of infertility has been increasing, and it increases with age. So since in our culture we have begun to push back the age of initial childbearing, we're seeing more people deal with infertility. About 10 to 15% of reproductive age couples have difficulty conceiving. Infertility can be primary or secondary. Primary is they've never conceived. Secondary is they've conceived, had a successful pregnancy, but are now having difficulty conceiving. One of the first things we need to look at is the menstrual cycle, or is the window of fertility. So we're going to look at the menstrual cycle, and I want to pull that up. Okay, I had to go find that. So wrong picture. Here we are. We're going to go back to this menstrual cycle, and we're going to look at the window of fertility. So on this cycle, which is the average, perfectly average cycle, ovulation occurs on day 14. Remember that the follicular phase can be longer or shorter. The luteal phase is usually not. So sperm can remain viable in the reproductive tract in the female reproductive tract for 3 to 5 days. So if we're at day 14, we can go back 3 to 5 days. And if that person had intercourse, had unprotected intercourse, let's see, 5 days before day 14 would be, goodness, 14 minus 5 is 9. Wow. Day 9. So day 9, okay. And then an ovum can be successfully fertilized for 12 to 24 hours after ovulation. So up to about day 15, okay. So we tend to think of getting pregnant as the ovum has already been released and the sperm finds it immediately, but sperm actually take a couple of days to travel through the reproductive tract of the female. And so they may be still traveling or still hanging out in that, in the fallopian tubes when that ovum is released. So they can remain viable for 3 to 5 days. The ovum can be successfully fertilized for 12 to 24 hours after ovulation. So we've got a window. Okay, you could also draw that on a timeline. You could draw 28 days on a timeline, pick where ovulation would be. So if that person ovulates on day 10, then they would be fertile from day 5 through day 11. And then they would probably have a luteal phase of 14 days and have a shorter cycle. It wouldn't go a full 28. So that's kind of how we look at the window of fertility. That's really helpful when we're trying to conceive. It's also helpful when we're trying not to conceive. So we'll look at that in a bit. So there are some requirements for normal fertility. Male, in order to have normal fertility, needs to have normal hormone function. Okay, they need to have the ability to produce semen and to produce sperm with normal motility. Most of the semen is not sperm. Most of the semen is a vehicle for the sperm. So if they can produce sperm, but they cannot produce enough semen, say after a prostatectomy, that sperm really can't go very far. So they have to have semen and they have to have sperm that have normal motility. They have to have the ability to achieve and maintain an erection and the ability to ejaculate near enough the cervix for the sperm to get there. So if you remember when Ms. Parker talked about sometimes the urethral meatus doesn't end at the tip of the penis. So if ejaculation is partway down the shaft of the penis, it may not get to the cervix. Okay. For female, women have to have normal hormone function. They have to have ova. They have to have eggs that can be released. They have to have the ability to ovulate, the ability for those follicles to ripen and to actually release the egg. They have to have a patent cervix, uterus, and fallopian tubes. They have to have fallopian tubes that have normal peristalsis. They have to have normal fallopian tube motility to move the ovum down. And also, once that ovum is fertilized, to be able to move the fertilized ovum down. They have to have cervical mucus that allows sperm to penetrate. So during that menstrual cycle, remember that I said the characteristics of the normal mucus that's produced by the cervix is it changes through the cycle. Around the time of ovulation, that mucus gets very thin and slippery like egg whites. And actually, one of the tests that they can do is called spin barcate. They can take it between two fingers and stretch it. It gets real stretchy. Okay. So the cervical mucus has to be thin and slippery enough to allow for sperm penetration. The rest of the cycle, when that person is not fertile, the mucus is actually thick and sticky. And the uterus has to be capable of supporting implantation and nourishing growth and development of the embryo and fetus to term. So there's a lot of working parts here, a lot of moving pieces. If we're assessing patients with fertility concerns, we may be assessing a couple. More and more often now, though, people are choosing to try to have children maybe when they're not partnered. And so maybe we're using some assisted reproductive technology for someone who does not have a partner to be able to give birth. But right now we're looking at infertility. So when we're assessing fertility, when we assess female fertility, we want to assess general health first. Both obesity and underweight are associated with impaired fertility. Obesity can also be a sign of androgen excess. So there's a condition called PCOS, polycystic ovarian syndrome, that causes a particular set of problems. It causes weight gain, it causes masculinization, the voice deepens, they may grow facial hair. It causes some risk for cardiovascular disease and diabetes. Also affects fertility because the follicles ripen, but they cannot actually release the ovum very easily. And so that they end up with multiple cysts on the ovaries. It's called polycystic ovarian syndrome. So obesity can be a sign to look for something else. Okay, look for another cause. If that woman has a history of reproductive infections, that can cause some scarring that can interfere with either the ovum getting through or the sperm getting to the ovum. It can also increase the risk for ectopic pregnancy, because once that ovum is fertilized and begins to divide, then it may get stuck in one of those locations that's scarred. Menstrual history and current menstrual cycle pattern. We want to know, has this person had regular menstrual cycles? Typically, is there anything in their menstrual history that would make us think that might be a reason for infertility? They're probably going to get blood drawn for hormones. They're going to get have a test for anti-spermatozoal antibody. Some women actually form antibodies against their partner's sperm. So the sperm is destroyed before it can ever get to the ovum. We might use some techniques to help that woman predict ovulation. Either there are predictor test kits, and there also are physiologic signs of ovulation. And when we can teach them how to predict ovulation so that they can have intercourse at around that time. If we're not sure that the tubes are patent, if the fallopian tubes might be scarred, a hysterosalpingogram may be done. That's dye is injected through the cervix into the uterus, and it would go through the fallopian tubes if they're patent. Typically, that's done if there maybe is a history of some infection or inflammation or endometriosis. If endometriosis is suspected, they might also do a laparoscopy, and then the cervical mucus might be analyzed. So that's a whole lot of testing that women go through for infertility. To assess male fertility, we look at a semen analysis for sperm count and motility and for the other components that are needed to ensure that sperm survive. A sperm penetration assay tests whether the sperm is able to penetrate the ova. A scrotal ultrasound might be used to look for abnormalities that might decrease sperm production, and a testicular biopsy might be used to determine if there's functioning tissue. So there's a lot more testing and a lot more invasive testing most of the time for women that are undergoing fertility management. The next thing we're going to look at is interventions, medical and nursing, to help manage infertility.